Well, welcome to our webinar number 2. This is our second webinar that we've run from the Prostate Cancer Foundation, Practicalities of Living with Prostate Cancer through this COVID-19 environment that we're all experiencing. Today we're going to take more of a medical focus to supporting our men. So thank you for joining us. Like a lot of New Zealanders, the team at the Prostate Cancer Foundation, we're all continuing to work from home. And while our prostate cancer support group meetings are not running currently, we're working on a number of ways in which we can continue to support members and their families and the wider community who are living with prostate cancer. We had to cancel our annual conference that was scheduled for early next month, but through these webinars, we're looking to provide comparable and helpful information. I'm Graham Woodside, and I'm going to be fronting this webinar with our guests today. Just a little bit of housekeeping before we get underway. Participants, you're joining us today in video only mode. However, there will be opportunity for you to ask us questions of any of the panelists during the course of the webinar. And you can do this through the Q&A icon at the bottom of your screen, or at the top, I think, if you're on a tablet. Just click on the icon and type out your question. If you'd like to be anonymous, there's an option for that. But please don't use the chat or the hand up functions, and also note this is a different viewing setup to Zoom meetings that you might be familiar with, and you aren't able to see all the participants who are joining us. You can just see the panelists. So let's get going. And firstly, I want to introduce Dr. Fritha Hanning. Fritha's based in Auckland, working at the Auckland DHB and also privately at Canopy Care. She's a medical oncologist who specialises in prostate cancer and has got considerable experience running clinical trials and also research along with the GU team at Auckland. She's also the Service Clinical Director for Medical Oncology in the Northern region up here. So welcome and thanks for joining us, Fritha.
Oh, thanks for having me.
Also like to introduce Sue Osborne. Sue's a nurse practitioner in urology based at North Shore Hospital in Auckland. She's actively involved in the diagnosis and treatment of men with prostate cancer and runs both face-to-face and virtual clinics with her patients. They're men on active surveillance, hormone treatment, and those also having surgery. Sue's also a member of the board of the Prostate Cancer Foundation. So Sue, welcome. Thanks for joining us.
Thank you, Graham, and thanks to the Foundation too for putting together these webinars.
It's good, thanks. And the other panellist today is Raymond Pavia. Raymond's our National Support and Education Manager at the Foundation, and she's also a registered nurse. And so Raymond's going to be managing the questions that you send through, which we'll address during the course of the webinar. So Fritha, I just want to start with you. In this COVID-19 environment that we're all currently experiencing, some men who are undergoing treatments of various types will be concerned that they might be at higher risk. So can I get you to explain whether they are indeed at any higher risk? So let's go through a range of treatments. Let's start off, men who've had surgery.
So maybe actually if we just start with the general context of COVID-19 in New Zealand, because I think when we all went back only a month ago now and started preparing for COVID-19, you know, in the medical community, we were looking at what you were all seeing as well, in contact with our colleagues from New York and Italy and planning for that eventuality. And obviously, thanks to the really decisive action of the Director General of Health and the government, we find ourselves now in a very different position in New Zealand. And I think because of that, we are now in actually a world leading position in terms of COVID-19 response. What that means is that the risks that we might have been facing to our health are not the same as they would be overseas. So that's a great point of reassurance. So at the moment, coming into hospital and considering having a surgery for prostate cancer, there is very little risk to you of that. Our hospitals have really robust processes for protecting you when you come into hospital, and they also have very few patients with COVID in hospital at the current time, so people do not need to feel worried about coming in for surgery. the risk at the moment is actually much greater of having untreated cancer, and thankfully our health services are not overrun and are in a good position to actually respond and get started with all of those surgeries that are required now. So I think people can feel really confident coming in for surgery. In terms of the post-operative period, we should all be doing the same things that we would be doing in a post-operative period, which is staying in our bubble. So it's sticking close to home and eating well and looking after our health and getting out for brief periods of exercise in the fresh air. So all of those things that we actually would normally recommend to people post-operatively, we would be recommending at the moment as a really good way to respond to COVID as well. So I think there is very low risk from surgery right now.
What about men who are undergoing radiotherapy or have had that recently?
So with the radiotherapy treatment, thankfully radiation treatment doesn't have quite as much impact on your immunity as something like chemotherapy, and we'll talk about that next. But in terms of coming in for radiation, the actual radiotherapy itself and the period afterwards is not putting you at any major increased risk. The only thing, caveat to that, is that obviously you're coming into the hospital and therefore into contact with lots of other people much more frequently. And so what we have done, and I know that this is consistent throughout the country, is that we've, as healthcare providers, we've put steps in place to enable people to keep social distancing even when they come for treatment. And so you can see some changes there in our workplaces to enable people to be safe. So when you come in, we're getting people to stay 2 meters apart. You won't be sharing a waiting space with another person, for example, now. And that's about our staff keeping people safe who come for treatment, because we recognise during radiotherapy you'll be coming in more frequently. The other thing that the Radiation Oncology Working Group, and just remembering I'm not a radiation doctor, but what they have been doing is looking at implementing some of the things that have been recommended internationally around fractionation schedules more quickly to protect people from COVID. What that means in English is how many times you have to come in for your treatment. So there is some research that suggests you may not have to come in as many times, and it is safe to give a slightly higher dose on fewer occasions and get just as effective treatment. And so our radiation colleagues have been working hard on getting those things in place to keep people safe.
Great, thank you. Let's move on. Guys on hormone treatment, or even guys on, who are on abiraterone or something, and also I understand also there may be some effect with the steroids that they're on if they're on abiraterone as well.
So with abiraterone or hormone therapy, there is a slight reduction in immunity, but once again, it's very mild. And at the steroid dose that we have with abiraterone, which is actually minimised, the risks is not comparable to, say, the risks that you might see when someone's on prednisone for rheumatoid arthritis. So might be having 40 or 60 milligrams of prednisone. Men on abiraterone are generally having 5 or 10 milligrams, and the risk to our immunity of that is much less. So we can't say that there's no impact on immunity from that, but it is actually quite minimal. And so I think for men on abiraterone or hormone therapies, just following the general guidelines for older people in terms of COVID is sufficient. And they can be really quite confident that their risk is not hugely elevated.
Now, you mentioned chemotherapy before. I'd like to talk a little bit about that.
Yeah, so that is where there is a difference. So when you are coming for chemotherapy, we absolutely know that there is an impact on immunity. But the risk of COVID actually in New Zealand and the benefit that you might get from your chemotherapy, when we're weighing that up with individual clients, we might still feel that for a lot of people, the benefit's still in favour of having the chemotherapy. But that's an individual decision, and it needs to be talked through with your clinician. The government has allowed us to use some immune boosting medication with chemotherapy, which they normally would say would be reserved for chemotherapies that profoundly affect immunity. And the docetaxel, which is the usual chemotherapy in prostate cancer, that normally wouldn't qualify because it doesn't affect immunity as much as some of the other types of chemotherapy. But at the moment, Pharmac have said to us, we're very happy for you to go ahead and use that immune booster for every patient. And so a lot of times that's what we're doing, and just making it safer for people. And that's an injection that gets given 24 hours after the chemo that helps to boost the immunity to protect people.
Yeah. Now, some men with advanced or metastatic disease may have some lung lesions or something like that. Is that going to be a risk?
Most men with cancer in their lungs from prostate cancer don't have a lot of the symptoms and side effects that would be there for patients with lung cancer. So where the cancer started in the lungs. Unfortunately, we do know from international groups that if you have a lung cancer that has started in the lungs, you are at higher risk of COVID and do need to take extra precautions. But I think if you, for example, know that your lungs are not very healthy, and that maybe you had asthma or you've had a long smoking history or something like that, then those are the people I think should be a bit more cautious with respect to COVID. So this is a really good time if you're a smoker to stop smoking. The smoking is probably a higher risk than having cancer in the lungs from your prostate. Right. So I would, if you're contemplating being an ex-smoker, this is a fabulous time for that step. Yeah. And that would do more to protect you than anything else.
Thanks. Let's go to Sue. Sue, you'll also be dealing with men who are concerned about their risk. And what are you telling them from your perspective, from a nursing perspective?
I think Fritha has made points really well there, and I think we can all take heart from the really low numbers of COVID-19 that we have in our community now, thanks, as Fritha was saying, to the leadership that we've had from the government and from the health department. I think the message, of course, is to stay as much as you can in your bubble, and certainly while we're at level 4, but to recognise that often your clinicians have ordered scans or treatments for you that might need you to leave your bubble, and that the person who has ordered those tests or treatments will have tried to work out for you the risk of leaving your bubble versus the gain that you'll have from having the treatment or the test done. And I'm sometimes finding I might have ordered a scan for someone, and they've rung, they're getting a bit of pain, I'm a bit worried about their PSA, and I've explained to them why they might benefit from a scan so that we could perhaps see if radiation treatment might help their pain. And then a few days later I get a notification from the radiology department saying the person's declined the scan because they're worried about COVID-19. So what I would be really grateful for, and I'm sure many clinicians would, is maybe if you're really worried about that risk, get in touch with whoever might have ordered the scan or one of the nurses at the department and just check on that, because it's quite a lot of work for everyone to reorder a scan or rearrange a treatment. And up front, we will have really tried to work out for you the risk versus benefit. But of course, it is always your decision, and as long as you're informed, then of course it's your right to decide. But as an underlying message, take heart from the really low numbers. The risk in the community is very, very low now, and the benefits from the treatments and the tests far outweigh that in most cases.
Thanks. We understand that some of the procedures in the hospital system, particularly biopsies and surgery, that they've been put on hold. Is that correct?
Sorry.
Sue?
I guess if I talk about a couple of things, radical prostatectomy and biopsies maybe first. Yeah. Radical prostatectomy has on the whole been put on hold for the 4-week lockdown period. There have been a few DHBs who have done some high risk surgeries over the last week or so, and certainly that's starting to ramp up already as we go into level 3 next week. There was a lot of work done right at the start where throughout New Zealand the urologists would have looked at their wait lists and worked out who was likely to be at risk from their surgery being delayed longer than it might have otherwise been by COVID-19. And groups of men have been offered, and many have taken up the opportunity to be on hormone therapy just to mitigate that risk while they're waiting. So hopefully that's reassuring information to know that it's not just that the door was shut. There would have been clinical thought given to each of the people on the waiting list and what that delay might mean to them. With regard to biopsies, again, most DHBs have stopped those. I believe a few DHBs, like for example, Northland, have done a few high-risk patients. Part of the rationale for stopping them was always the small risk of sepsis and what impact that might have on someone presenting at an emergency department that may have potentially been overloaded with COVID-19 patients. Thankfully, that hasn't happened, but that was something we had to factor in when that decision was made. But biopsies are already up and running from probably next week in most DHBs, or certainly the week after. And there have been clinicians looking at the people waiting on the wait list and prioritising those early appointments so they're given to the right people with the highest risk. If I can talk about our DHB, we only have 30 people waiting for a biopsy, and we will have the top 15 of those will have had their procedures within the next 10 to 14 days. So that's quite reassuring. The booking clerks did, however, tell me this morning they were having trouble getting people wanting to come in. So I think there's still that underlying fear about the risk of coming into hospital versus the potential gain of getting on and finding out if you have a prostate cancer and getting it treated if you do. So I'd really like to stress, as Fritha did, the hospitals have done such a lot of work mitigating that risk, and if you're offered an appointment, really think hard about whether it's the right thing to do for you. Fritha, do you want to add anything there?
No, so I think that's really comprehensive. It's great to hear those numbers from your DHB because it just shows that we've actually, we can get through this and get into a new normal.
Yes, and I suppose we have to factor in that over the last 4 weeks, men haven't been going to their GPs for men health checks, having their PSAs done. And so we actually have had a very low number of new referrals. So we don't have a backlog of people waiting either.
And I guess that's a good thing for the community to know, though, is that the GPs are still there. So as we step down out of this, if you are due for a well man check, this is a really important time to get onto that.
Yeah, absolutely.
So some men, if they have been delayed, they haven't been able to get their biopsy, or they've been waiting for surgery, they'll be concerned that the cancer may be advancing and they may be in a worse state than they were. Sue, comment on that?
I guess first of all, just taking heart from realising that the DHBs have done a lot of groundwork here, which perhaps people won't realise. Before this webinar, I did email a lot of my colleagues throughout New Zealand just to say, well, what services have been running over this 4-week time. And I'd like everyone to know really that referrals that have come through have still been triaged, they've still been graded according to the same guidelines that we would always grade things. Tests, investigations like scans that would influence the ability to change a treatment or give a treatment in a timely fashion have on the whole still been happening in a timely fashion. And that's a bit different to say surveillance scans, which we can talk about later on active surveillance protocols, but those scans that are really important up front to decide whether disease is advanced and whether treatments need to happen urgently, they have been happening. Consultations have been happening, albeit that a large number of them are over the phone or through telehealth forums. And so the wheels are still turning, albeit in a way that's different to what we're used to. So with regards to the risk, I guess that we can't promise you that there's absolutely no risk, but there's certainly been a lot of work done to mitigate that risk and to get ready to ramp up as quickly as we can as things get closer to normal.
So if guys are really concerned about that, what should they do? Who should they call to try and get, to know where they are in the queue when it starts again?
Yeah, that's a really good question, and I guess it's the bottom line, isn't it? Because if you're the person and it's your journey, then you need to know how to get hold of that information. So many DHBs do have prostate cancer nurses like myself, and we're always a good point to start with, but not all DHBs do. There is an equity there. Most will have a urology nurse, whether it's someone who's an outpatient who's identified as having some expertise. And if you actually are in a DHB, in a care service where you don't have a clue who your nurse contact might be, sometimes the booking clerk is a really good place to start, where you can ring the booking clerk and say, I'm really worried, I know I'm in a queue. Sometimes the booking clerk can let you know when your appointment will happen or your surgery will happen. And if they can't, then they will generally know who they can pass that message on to, who can get back to you with some clinical information. The other thing is GPs have a really efficient way electronically of flicking us messages. So you can say to your GP, I'm really worried, I don't know where I'm up to, and they can flick us a message on your behalf and we can get straight back to them. That's a couple of my suggestions.
Great, that's good. And you're doing some clinics by telephone or online. How does that work? How should guys respond to that? Are guys comfortable talking over the telephone, or would they rather be face to face?
Do you want to go first, Fritha, or shall I carry?
I can, I guess I would just be saying that we're all learning about telehealth. This is new to us as well. And so, you know, the doctor or nurse that you're talking to will be finding their feet with it, but generally people have been very receptive to it because it's actually taken some of the stress out of travel. And we have found, because we're looking at the number of people who don't turn up for appointments, and at the moment it's almost zero. Everybody turns up because you can be contacted at home. So there's some advantages about that, but one of the challenges is, of course, we can't see, you know, what the thing that you're concerned about looks like, and those sorts of things. And so sometimes we are having to ask people to come in just so that we can have a look at where something's painful or what's going on with that. Yeah, so did you have anything to say about that?
Yeah, I think I totally agree with you, Fritha. It's learning for both sides, and anecdotally, the feedback has been really good through our service as well. I think it's hard to underestimate how much of that might be because people are just so pleased to be able to access specialist advice during this time of lockdown when perhaps they thought they might not be able to. There's been a couple of bits of feedback through our DHB, not specifically for urology, but where doctors had phoned patients at times other than that they were expecting to be called. And so they had felt a little underprepared, perhaps didn't have their support person there or their list of questions there. And so our clinicians were asked to try and remember that when we call. So what we've been trying to do is set it up pretty much like a phone, like a clinic appointment. So it will be 11 o'clock on Tuesday. Sometimes it's not that specific. It's like it'll be between 9 and 12 on Tuesday, and please stay by your phone. I guess 3 bits of advice I've thought of for people who have not found it as satisfactory is, one is that if you do get rung out of the blue, it is okay to say to the doctor or the nurse, can you give me 30 seconds to get my wife to the phone, to put it on speaker, to get my questions? And most times that's fine. And if the doctor can't wait or the nurse can't wait, you can negotiate a call back, but generally they'll be able to. The other thing is that a lot of times the letters from the consults that go to the GP will go to the patient, and you might want to ask, am I going to get this information in writing? Because you might not remember it very clearly, in the same way that you might not when you're in a consultation room either. So that's something you can ask for, or can you post me out some written information about prostate cancer or about radiotherapy or whatever's been discussed. And the third thing I think is that ask if there's a contact number for someone they can ring after the phone consult tomorrow if you've suddenly said, why didn't I ask this? And if there isn't at your DHB, then maybe you can ring the booking clerk and just say, could someone ring me back? If they're not able to give you a contact number of a specified person, often you can just say to the booking clerk, I'm a bit bamboozled by yesterday, do you mind asking if someone rings me back? And hopefully that might just make those consultations a bit better for people who haven't found them so.
The other thing just to say is that we have worked out a way now of conference calling in other family members and things, and obviously skill levels across the country might not be quite there yet, but we'll all get better at it. And so if you do want a family member to be conference called in and they're not in your bubble, it's also okay to ask about that. There may be the possibility to do that.
Yeah.
Fritha, what's happening with oncology treatment processes during the lockdown and clinical trials?
Yes, so to answer those two separately, so at the moment, just to reassure you, we haven't done any less work. In fact, we've been doing more new patient appointments and consultations than usual, because absolutely everybody is here and no one is on leave. And so waiting times should be just normal at the moment across the cancer service. But one of the things that we did have to make changes to during the lockdown was recruitment to clinical trials, because clinical trials do have particular regulation about how things get done. And so if you can't meet the obligations of the clinical trial, then you are not allowed to continue recruiting. And we've been working hard to fix that. We are about to begin recruiting again in a phased way, as we can do that safely. So we have been stopped for the last 4 weeks, but that is about to ramp up again. But it will be in a phased way, and we're trying to prioritise those clinical trials where it is a treatment which otherwise doesn't exist for people, rather than just a treatment option where there is a standard of care option. So we're prioritising those situations where people can't choose to have a different therapy. Right. And so we would be very hopeful that over the next 6 to 8 weeks that we will be getting back up to our usual capacity there. But there is this this need to do a clinical trial in the appropriate way that we've had to work our way through. Yeah. Those patients who've been already on clinical trials, though, they have been continuing with treatments as per usual.
Right. Look, just a reminder to you who are watching this webinar, if you've got questions, please feel free to get them in. I see there's a couple there. Raywin, have you got one that we could take now?
Yeah, absolutely. So this one is for Fritha. What exactly is the immune booster with chemo?
Yep, so there's a treatment called pegfilgrastim. I don't know why they have these terrible names, but it's a little injection that's a bit like a diabetic injection. It just goes under the skin, and it gets given a minimum 24 hours after the chemotherapy. And what it does is it sends a message to your body to make immune cells. So one of the things with chemotherapy, if you imagine that your bone marrow in your body is making new blood all the time. And so there's a little conveyor belt with baby blood cells coming out every single day. When you have your chemotherapy, the conveyor belt stops. And so when those babies would have been adults, you have a shortage for a short period of time until it comes back to normal. What the immune booster does is it shortens that period, because one day after your chemotherapy, you have a message to make lots of them. And so that when you would have had a shortage, you then have a more normal amount of immunity. So it's not a total precaution, but it helps a lot. And so that's pegfilgrastim, and it gets given a minimum, it has to be over 24 hours after the treatment.
Great explanation. I really like the way that you can put it in terms that we can all understand. That's great.
Thank you.
There is another one here, Graham, for Sue, if you don't mind me just asking. Is it come up on the screen? Is there any other options for bladder control? Pelvic floor exercises do not seem to produce the desired outcome.
Sure. Is this in a post-surgical setting, or they haven't really said?
Sorry, I haven't shared that.
Yeah, no, that's fine. Pelvic floor exercises do tend to be the mainstay, don't they, of bladder control. And remember, it takes a good year after surgery of continued healing and improvement until you kind of reach the level that you might end up at with regards to bladder control. There are surgical interventions. There are devices called dribble stops, which we use from time to time, particularly if the incontinence is severe and you've got, say, a special function to go to, which nobody does at the moment, but that will happen again. I guess it's about communicating. It's about making sure you're not too shy to let the nurse know or the doctor know who's following you in your post-surgical setting when they're checking your PSAs and your recovery. There should be a focus in the questions on your continence and return of erectile function if that's relevant. So make sure you communicate that you know you really are struggling with the degree of incontinence that you have. There is no simple fix. It may be that you're not doing the exercises as well as you could be, and that's through no fault of your own. It is, you know, a bit of a learned skill. So a referral through to a physiotherapy service could be helpful as well. And Graham, you might want to talk about the Prostate Cancer Foundation welfare grant if someone's really struggling.
Yeah, so physiotherapy generally isn't funded post-surgical, but we have an arrangement with some of the physios through the Pink and Steel organisation where we can support some funding for some physio treatment. So yeah, if that's something that can be of help, then look on our website under our support tab, I think it is, and welfare grants, and you can make an application there for some funding. But probably the first step is to go and talk to one of the physiotherapists, and then they can help you through that process.
Yeah, and don't despair, because if it does seem like a long journey, often it really does while you're going through it, and then you look back when things get a bit better and go, oh, okay, I got there. If I knew I was going to get there and things would come right, I could have managed that and dealt with the worry and the concern a bit better. It's the not knowing, really, isn't it, often as to where you're going to end up with regards to return of control. But if there is, a less than ideal outcome at the end and it is impacting significantly on your mental well-being or your quality of life, there are surgical procedures and other things that can be done, and pelvic floor exercises aren't all that there is. So just make sure you communicate with your healthcare provider around that, and don't be shy.
Sue, the gentleman that asked this question has actually expanded a little bit, and he'd like to know that in regards to, is there a difference between the public system and what someone would get if they'd gone private?
Not really, I don't think. I think most DHBs don't fund pelvic floor physiotherapy unless it's a really, really poor, an unexpectedly poor outcome in the beginning where they're really struggling with it more than we would expect that they perhaps should be. So generally, unfortunately, it isn't funded, certainly at our DHB, and people do go private. So therefore, in the private sector, it would be the same. Obviously, I don't work at all DHBs, and I'm not sure if some of the other DHBs do have the ability to provide some pelvic floor physio as a matter of course. But I think not.
Yeah.
Yeah.
That's my general understanding, because we get applications from all around the country for to support men through that process. Here's another issue. A number of men will be on a schedule of regular PSA tests, either on active surveillance or following their treatment or whatever. They'll be on 3 monthly, 6 monthly PSA tests. Currently, they may not be able to access the doctors and maybe not be able to get that. Is that a concern? Some guys I know will be worrying about this.
Do you want me to speak, Fritha? Because your population are probably slightly different, aren't they?
Yes, absolutely. You go ahead, Sue.
I guess in the active surveillance, there are multiple groups within prostate cancer, obviously. So for men on active surveillance, very much take heart that the reason you're on an active surveillance protocol is you've been identified as having a very small amount of very low risk disease. And if you've passed your first 1 year where you've probably had 2 biopsies and an MRI, then we've got some real certainty around that, and some small delays in your PSA testing, provided it's been stable, are not a concern at all. And really, we're really looking at sort of another couple of weeks only, aren't we, where things, well, before things return towards normal. Post-radical prostatectomy, it's the same really. If your PSAs have been perfect all along, then a few weeks or even a couple of months delay really is not of concern. However, it's about you and where you're at with that, and some people do really worry when their PSAs come up. So there's no reason why you can't get a PSA now as we go out of lockdown. The labs are open. There are people to order a PSA for you, and you can go along and get it and have that result reviewed. Certainly, if you are, say, maybe on hormone therapy, before lockdown, your PSA was starting to go up a bit, maybe you have now started to wake up with a little niggly pain in your hip, things are changing for you, then it becomes really important that you have the ability to access those assessments and including blood work. So please do talk to your GPs, they are there, talk to us, and don't delay, particularly if you have symptoms. That's really important.
Any comments, Fritha?
Yeah, I just wanted to say, obviously, that's not quite the same issue with the men that I usually meet, and that we've mainly been having PSAs throughout. But some of the labs have provided, and it is worth looking on the website, provided times for patients who have immunosuppression, so that you can feel more confident that you're not sitting in the laboratory with someone with cold symptoms, for example. And so it is worth having a look at that to see whether you can take advantage of that in order to go and have your tests taken.
That's good.
Yeah. And similarly, some men will, after a few weeks, that they'll be concerned that they're getting near the end of their medication supplies, or they're due for their next hormone injection. What should they do?
So all of us now are set up to do prescriptions. So there has been a change to the legislation actually to make it more easier for your doctors to send prescriptions direct to your pharmacy. And what we call a wet signature is no longer required. And so we are able to do those things virtually, which we haven't previously been allowed to do. And so it is possible to get a script through to your pharmacy. So if you make contact with the person who normally does your scripts, they can send a supply through to your pharmacy. And a lot of the pharmacies now are actually happy to courier it to your home. So it's worth asking about that service. So you can potentially, just by using your phone, get access to those medications. In terms of the having the injections, your Zoladex and things, there is a little bit of flexibility if you've been on that medication for a really long time. If you are just starting on the medication, it is important to have it exactly on time. But if you've been on that medication for a really, really long time, a shift by a couple of weeks is very unlikely to cause any problems. But of course, most men are still getting into their GP practices or to our services to have those injections done. And so there doesn't seem to be too much barrier there.
Now, what I guess a lot of guys would like would be a virtual Zoladex injection.
Well, that would be brilliant. If someone could make that not such a big injection, that would be fantastic.
They tell me they're not very pleasant, so yeah.
We've got another question here on the PSA, Graham, if we could just go to that while we're talking about it. From the participant in the audience is asking, what if your PSA is not stable?
So if your PSA isn't stable and you are needing a change in therapy, or needing to come up to some therapy, you should be accessing treatment as you normally would at this time. So the COVID situation shouldn't be a barrier to that. So if you know you have a rising PSA, then you should actually go to the lab and have your test taken and access your health practitioner as you normally would, because obviously the risk-benefit balance there, particularly given that there isn't much COVID in the community at the moment, is in favour of actually having that managed. So I would go ahead and see your doctor in that situation. Yeah.
Completely agree.
Rowan, another question.
Yes, we have. We've got a question here from a gentleman saying that he's 18 years plus down the road on his journey and he's not had a surveillance scan since the 2nd year. His question is, would it be advisable to have a scan? And he is asking some questions as to how you arrange this. He doesn't have an oncologist in New Zealand and he had the procedure carried out in Australia.
So we generally talk about the triad when it comes to prostate cancer, which is your PSA, how you feel, and the scans. And so if 2 of those things are holding hands, then you're probably okay. So if your PSA is under control and you feel fine, then you're very unlikely to need a scan. For most people, the PSA and how you feel is telling the truth. If your PSA is going up, but you feel fine, then you need the 3rd thing to tell you the answer. You need the scan. And so if he feels 100% fine and his PSA is under control, then it's very likely that he can be reassured. Yeah. Equally, if your PSA is under control, but you feel terrible, then that needs to be looked into with a scan.
And it may not be related to the prostate cancer that
May
you feel
not.
terrible. So see your GP. You might have some completely different diagnosis too. Yeah,
that's quite right. I mean, your GP might find that it's something totally unrelated. Yeah.
No, that's a good way of looking at it, Fritha.
Raven.
So the next question is actually for Sue. So you mentioned mental health factors briefly regarding erectile dysfunction. It depends on a man's treatment and supports to how they cope. It is one of the difficulties in coping with this problem. With the pressure of changes that the lockdown has created for some men and their partners, it may be helpful for them to have access to a professional counsellor, such as a psychologist. Would you like to comment on this, Sue?
Yeah, sure. There are health psychologists and cancer psychologists in many DHBs now, but the way they are funded and placed in the treatment trajectory varies quite a lot. For example, at our DHB, they're funded to be involved in the kind of diagnosis space pre-treatment, and they don't have, unfortunately, funding to be involved in the scenario where you're talking. So I guess it's a matter of checking out with the service that you're under whether your service has access to cancer psychologists, health psychologists, and where they are funded to be placed in the journey. The other thing I guess is important is thinking about the Prostate Cancer Foundation support groups and the helpline there. If it's someone to talk to, they may be able to give you someone that you can share your experiences with, or information regarding some health psychologists or sex therapists that have been recommended by others or are known to us. It is a tricky area because, again, there's not a lot of funding, but it is an area where things are improving. Fritha, have you got any?
Just to add that the Cancer Society do have counselling services which patients can access. Yeah, and so you can be referred to the Cancer Society counsellors.
Yeah.
And again, we can help with funding for some counselling sessions through our welfare grants program as well. Yeah, so we do that. Look, some men will be finding the isolation and the social distancing and all of that quite a challenge, particularly, they may be going to support groups and had the opportunity to mix and mingle and talk through those issues. It's a bit related to that, what we've just been talking about. What advice can you give them about their general coping in this environment that we're in? So let's go.
Go first? Sure. I guess we really need to acknowledge, don't we, that we are social beings, humans, and so for us to be confined within a smaller network, whether it's 1 or 2 people in our bubble, for many of us is a challenge. Some people not so much. Introverts apparently thrive really well, and other extroverts maybe not so much, and they need a wider circle of contact. And you'll know, everybody that's listening, more about your own personality and how that's affected you. I guess it's about communicating to the people within your bubble, doing activities together, whether it be puzzles or cooking or getting out the photo albums, reminiscing, those sorts of things. So there's a real human connection. You're not just sort of side by side in the bubble and not having those sorts of interactions. of course, technology has been huge in helping people reach out to their grandchildren and wider families and friends beyond the bubble. And that has been something that some of the younger generation have often had to help the others to master. But we've all had that little bit more time, haven't we? So those of us that aren't working just as hard as we have been to help that the people master those skills, which has been great. I think it's also, for me, I've sort of noticed people really stopping and noticing their environment a bit more around, you know, we're going a bit slower often, aren't we? We're going for those walks and the sun's shining and the leaves are changing and the kids are having fun, and it's really perhaps trying to let our soul feel those positive things and get those good feelings and strength from that. If worry is becoming overwhelming though, I think it is important to communicate that to the people in your circle, people who know you well, who can help you remember your coping strategies. And then if it's more than that, then with your healthcare provider, with the foundation, the support groups, and let us know if you need more help to keep that worry in perspective. Fritha, other suggestions?
I think that's a really comprehensive answer. I mean, I think it is about just going easy on yourself as well. You know, we're all struggling a little bit at this time. I keep saying to my children, this is a historic event. And so it's normal to feel like we're a bit discombobulated and we don't quite know what's going on. There are also, it's not a bad time if you are feeling like that, frustrated and lonely and things, to reach out to the groups that are out there. Because I'm sure that a lot of people are finding digital solutions to get around that. I mean, you've shown that you understand that capability by attending today. And so, for example, things like the men's shed, I've had a few men say to me that the men's shed has been an absolute lifesaver for them. And a lot of those places are running Zoom meetings and those sorts of things that you might be able to attend. So it's just another idea.
That's good.
Okay, so we're going to draw the webinar towards a close. Any final comments from you both, and you, Raywin, too?
I think just adding to what Fritha and Sue have said, anybody that's watched our first webinar, where we in fact had Chris Malcolm, who is a counsellor, sharing his views on how you manage during this time, and also the lovely couple that we had from Christchurch, Rob and Robin. So that webinar is up on our PCF website if you would like to watch that. But there's some lovely little gems that all three of them share, but Chris especially said things like, you know, when you're out there, look for, you know, the rainbows in the rain, and just, you know, really reinforcing what Sue said is really noticing and maybe appreciating what's around you and making the most of it, but also be willing to share it and be open. And I think the other thing that Chris stressed was live for the here and now. Don't worry about the future. Don't worry about the past. You actually might not be able to influence those, and that, you know, live in the moment and make the most of it. So yeah, I'd just like to, you know, if you haven't seen that and weren't able to attend that webinar, it really is worthwhile watching.
So I was just going to say, Graham, you know, thank you very much to the Prostate Cancer Foundation for running these events, and also for the opportunity to take part. You know, really just as a final thing to say that sometimes we can use these unusual times as an opportunity to stimulate ourselves to make really good health choices. You know, like I had a stern talk to myself about my licorice consumption, you know, in the last couple of days. And I said, you know, actually I could potentially make a choice to really look after myself right now, because if I do, then I reduce my risk for COVID. So I could make sure that I do all of the things, if I have the energy for it, that's going to make me more resilient to this. And that's, you know, eating really well, getting a little bit of exercise, trying to get the amount of sleep I need, drinking lots of water. Those are all things that, if we can, is a good option right now.
Yeah, that's good. And I think just knowing that we are coming back increasingly on stream, but we've always been here for even for the last 4 weeks, even if it's felt like we're in the background, not so much in medical oncology where it's been business as usual, but say with some of the services like surgery and biopsies where we haven't been. We're all here because we care, and we still care, and we're looking at trying to get you all back on track and getting your diagnoses and treatment as effectively and efficiently as we can, while maintaining, you know, safe environments for you and for the staff at the hospital. So yeah, and thanks also for the ability to participate today.
Thank you. So just as I said at the beginning, the team here at the Foundation, we're still working and we're still available to provide support and information if you need it. You can call us on the 0800 477 678 or go to our website, prostate.org.nz. As Raymond said, the previous webinars on there, also lots of other information, and there's also an online support forum where you can interact and dialogue with other people as well. And there's also our Facebook page, so there's lots of opportunities there to engage with us. So Fritha and Sue, I really want to say a really big thank you for providing your expertise and your insights today. We're getting a number of messages actually coming through on the questions saying thank you very much. So people are really appreciating that. And thanks to everybody who's joined us today. What we'll do is we'll send you an email with a survey and also a link to the recording. We're actually recording this webinar as well, and you'll get a link to that, and we'd really appreciate your feedback on this webinar. So I want to wish you well. I'm going to do my exercise now. My dog is there waiting to go for a daily walk down the road, which is great because being at home this time of night, I'm not usually home by now. So, so he's getting a walk every night. I'm getting a walk every night. So I wish you well. Keep safe. Goodbye. Thanks for joining us.